Welcome everyone who's here so far. I'm going to wait till 8:01 to start. We've got a jam-packed session, so I want to make sure we start early and have enough time for questions at the end. All right, so it's 8:01. We have a wonderful session for everyone tonight to relax them from their stressful days. We're talking about diastole, and we've got our esteemed presenters, Amanda Huck and Richie Palma with us tonight. We will introduce them in due time, but by our moderators, Megan Kornoyer and Matthew Theoharakis. Thank you for attending, and if anyone meant to join this call and from your institution has not, please text them to let them know we're live. Let's go to the next slide. Our sponsor page is here. We are lucky enough to be sponsored tonight specifically by Colorado Children's. And at the end, if there's a member still able to be on the call, we'll get an update from that, like a highlight from that program as one of our paid sponsors for SOPE. If you are interested in becoming a sponsor for SOPE to, for example, highlight your program during one of these sessions, we would be happy to have you. Please reach out to myself or one of the emails that you received from SOPE, and we will get you in touch with the right person. Let's go to the next slide. Looks like admin at SOPE Echo. And then here for sonographers who would like credit for attending this webinar, you actually can get credit by simply scanning the QR code. Unfortunately, and we were actively working on this as a physician, we don't yet have AMA CME credits, but we are actively working on finding a host organization to do that for us. So as of the moment, all sonographers can get credit, but physicians are here just for fun, and we thank you. All right, wonderful. So I'll leave it to our moderators to take over.
Right.
Oh, and I'll mention briefly, and we'll mention this at the end as well. Our next SOAP speed session will be April 28th, and the topic will be CCTGA. So another great session to attend for. But let's leave it to the moderators to introduce our speaker.
Great, perfect. So it's my pleasure to introduce Dr. Amanda Hawk. She is a pediatric cardiologist at Lurie Children's Hospital in Chicago with expertise in echocardiography and pulmonary hypertension. And we are very fortunate to have her here with us today. Just as a reminder, please go ahead and leave questions in the chat as we go, and hopefully we'll have some time at the end for them. So go ahead and share your screen and you can get started.
Great, thank you. And thank you to SOPE and the organizers for the opportunity to speak on a topic that I find interesting, although I know not everybody does. So hopefully by the end of today, a little bit of that will change and I don't drive everybody to hate it more. So relax, it's just diastole. I do not have any disclosures. I'm going to try to briefly just talk over the basic concepts of diastolic function because I think understanding them is important to understanding the echo. Give a quick snapshot review of some of the echo measurements we use because Richie will show them later and when he talks about the technical aspects of doing the measurements, but really understanding what the significance are of different diastolic measures and then very briefly talking about the new adult ACE guidelines that for diastolic function assessment that came out last summer, and then describe how these are applicable or not to the pediatric population. So to start talking about diastolic function, we have to know what diastole is. So diastole is essentially the time frame between the end of ejection to the beginning of systole. It's the time at which the ventricle fills, and diastolic function depends on how well and how fast the ventricle relaxes. And really, diastole should occur at low pressures because easy filling of the ventricle is necessary to maintain good cardiac output. And it's also the time in the left ventricle where coronary perfusion occurs. My mouse isn't working, which is going to cause problems. And you can see on the figure on the right that there are 4 separate time parts of diastolic function, and we'll talk about each of them in a little more detail on the next slide. So the first phase of diastole is isovolumic relaxation, which is after the aortic valve closes and before the pressure drops low enough for the mitral valve to open. This is a time when there is kind of energy use to relax the the ventricle. And you can see this kind of squeeze ball on the left. What happens in systole is that the ventricle kind of stores potential energy and then essentially snaps back to its resting state during diastole. And so that snapping back, or that elastic recoil, results in untwisting of the ventricle during isovolumic relaxation, which drops the pressure a lot. We then get early rapid filling, which we all know from our echo E wave. That starts when the mitral valve opens. There's ongoing recoil and untwisting of the heart. And what that untwist does is actually generates a lower pressure at the apex than at the base of the ventricle. And so blood is sort of sucked into the lower pressured apex of the ventricle. There's a period of diastasis where there's equal pressures in the atrium and the ventricle in adults and in kids with slower heart rates. And then late atrial filling is our atrial kick, or our A wave, when the atrium contracts and gives additional volume into the left ventricle. And that depends, how much that happens depends on how stiff or how compliant the ventricle is. And so these are just pictures showing some basic concepts of left ventricular diastolic or function, showing first how quickly the pressure drops very early during our isovolumic relaxation time, and then gradually increases over time. And in the picture on the right, this concept of compliance or stiffness, where you can see volume on the x-axis and pressure on the y-axis. And in a normal heart, as you fill with 100 mils of blood, the pressure goes up to about 5. If there's a very compliant ventricle, it can take on 100 milliliters of blood volume easily without much increase in pressure. But a stiff ventricle, by the time you put 100 milliliters of blood in it, has a pressure that's exorbitantly high and makes patients very symptomatic from heart failure. So those concepts are what drives the echo measurements that we see when we do these echoes. We know that I think everybody's probably seen some form of this progression and the different patterns that you see of different measurements in diastolic function, but this really pertains to adults who follow this sort of pattern of grade 1 or abnormal relaxation, where that relaxation phase of the ventricular function is abnormal. Gradually, with more severe disease, the compliance of the ventricle changes, which results in the start of elevated filling pressures. And then at its most severe, we get a very poorly compliant ventricle, very high atrial pressures, and left atrial enlargement. And those factors are what change the patterns of our mitral valve Doppler, our tissue Doppler, our pulmonary vein Doppler, and all of the other measurements that we do in our diastolic function. And I'll go through why that causes these changes in later slides. When we assess diastolic function, I think one of the key things to remember is that clinical history is important. So an asymptomatic healthy kid doesn't have diastolic dysfunction. The other thing to know is that no one measurement fully represents diastolic function. There's some that might be better than others, but no single normal means normal function, and no single abnormal necessarily means abnormal diastolic function. And Richie will talk about this a lot, but really high quality data is necessary for high quality interpretation. So if we don't get good information, we can't assess for diastolic function. We look at a lot of things. First, is there left ventricular disease? Because those are the kids that are at risk for diastolic dysfunction. And then look at things like our mitral inflow Doppler, our LV tissue Doppler, our tricuspid and our pulmonary regurgitation Doppler, because if we have high left atrial pressure, that causes back pressure into our pulmonary arteries and findings of pulmonary hypertension. Our left atrial size and function is important, and then our pulmonary vein Doppler. And then there's others, but I only got 12 minutes. So this is just a snapshot with the name of the measurement and all of the name of the view and all of the different measurements that we can do, just to say that all of these are important and in fact probably critical to truly comprehensively assessing diastolic function in anybody who's at risk. So we can't just pick some or avoid doing all of the measurements at high quality in kids who are at risk for diastolic dysfunction, or we'll miss it. So I wanted to kind of talk through, because I think it's helpful to understand exactly what's happening when we're then trying to interpret the measurements, because it sticks with us and it just seems more interesting when you know what you're looking at. So in grade 1 diastolic dysfunction, that abnormal relaxation, basically what happens is these bridges between the heart cells have to separate to let the heart muscle kind of relax back to its normal state. And so when there's abnormal relaxation, that happens more slowly, so blood starts to fill the ventricle more slowly, but it happens more slowly, which also causes the pressure difference between the left atrium and the left ventricle to be less. So you don't get as high of a velocity in your, this mouse is driving me crazy, across your mitral valve E wave. You get a longer deceleration time. Your E wave velocity is lower, but a key finding in all stages of diastolic dysfunction is your E prime is also lower. And because they're both lower, the ratio might not be abnormal. And because we don't have high filling pressures yet, our left atrial size is still normal. And so that's why we get this longer deceleration time, this low E to A ratio, and why the patterns that we kind of learn along the way for diastolic dysfunction are there with abnormal relaxation. On the other end of the spectrum, when the ventricle is very stiff, we start out with a really high left atrial pressure as a result of the poor compliance of the left ventricle. And so there's a really high pressure in the atrium. So as the LV starts to relax, that blood sort of pours out of the atrium into the ventricle, but the ventricle pressure goes up really fast. So you get high velocity flow and then it stops suddenly. So you get there's short deceleration time, but you get a really high E to A ratio. And then you get this A wave contraction where the atrium contracts and the ventricle is like, I am full, I cannot take anymore. So you get a tiny little A wave. And then one of the things that I think is really interesting to pay attention to is how suddenly or abruptly your A wave inflow stops. Because if your pressure is high, if your filling pressures are high, that's often very short and truncated. Because your E wave is really high and your E prime is now very low, you get a high E to E prime ratio and your left atrial size will be big. And then there's this in between because you have to go from the first pattern to the second pattern somehow. And that gives you these kind of in between measurements where, again, your E prime is still low using age specific norms. Your E to E prime will be high, but you may get a kind of normal measurement for your relaxation time, for your deceleration time, for your E to A ratio. And so that's one of the times where these tissue Doppler measurements can help distinguish between normal and what has kind of historically been called this pseudo-normal pattern. Diastolic function assessment is important because a lot of our kids can have diastolic dysfunction. In the neonatal period, you can see the list there. Anything from just prematurity or cardiomyopathy or pulmonary hypertension can be associated with diastolic dysfunction. And in our children, those who have been transplanted have cardiomyopathy, those with left heart obstructive lesions, but also kids with structurally normal hearts with kidney disease who have received chemo. And then we do have a growing population of those with hypertension and obesity who may be at risk for diastolic dysfunction. It matters also not just because they might have it, but because it changes how they do in the long term. So these are Kaplan-Meier curves that show sort of event-free or transplant-free survival. On the left in patients with hypertrophic cardiomyopathy, and looking at those who have a high E to E prime ratio that's abnormal for age, that's a sign of diastolic dysfunction. Those kids at 5 years only have 30% survival compared to those who have more normal diastolic function who have like 80% survival. So that's a big difference, the presence and the detection of diastolic dysfunction. And then adults with coarctations are kind of the same way. The more severe your diastolic dysfunction is, and these are young adults, like 20-year-olds, the more severe your diastolic dysfunction, the less likely you are to survive without transplant. The adults recently, so every few years, they put out new guidelines on how to assess diastolic function and heart failure with preserved ejection fraction. And I think the newest ones, they're still they're not being validated. They were validated before they were published, but they're being used more and people are getting the kind of a feel for them. I think one of the key things that came out of that is that even in the adult world, they've started to look more specifically at age-specific cutoffs for all of the diastolic function measures. And that's important for us because even in adults now, it may not be right to use the same cutoff for everything. And what the guidelines show is that to decide whether if somebody has diastolic dysfunction, you look for signs of abnormal relaxation, specifically your E primes. You look then for signs of elevated LA pressure, which one of the key features of the new guidelines is that left atrial reservoir strain has made it into the guidelines as one of the key determinants of whether you have diastolic dysfunction. And on the right side, essentially, if you have at least two things, then the adults would consider you as having diastolic dysfunction. we can't use these guidelines this clearly. They're not validated in children, and there's a number of reasons why that we'll talk about. If there is diastolic dysfunction, then the grading of diastolic dysfunction is the next step, which is similar to prior iterations of the guidelines. But again, it's possible, especially in kind of younger adults, to use age-specific cutoffs and then follow the tree down, and also using some supplemental methods. If there's not enough that you can use to say whether somebody does or does not have the different grades of diastolic dysfunction, you can now add in additional measurements like your pulmonary regurgitation, tricuspid regurgitation, I guess that's up there, pulmonary regurgitation, or the duration of your pulmonary vein A wave reversal longer than your mitral valve A wave of more than 30 milliseconds, which is pretty sensitive and specific for elevated pressures. Again, we can't use them. Why is that? Kids have fast heart rates. We have fusion of our E and A because of a shorter diastole. If adults have a wide range of normal values, kids have an even wider range of normal values. Neonates are a totally different beast. And some of the things that are abnormal in adults are actually normal in kids. So an E to A ratio more than 2 is very common. A predominant flow in your pulmonary veins and during diastole is much more common in kids. And kids don't follow the same progression from abnormal relaxation to abnormal compliance as adults. And then you throw in congenital heart disease and everything gets even more crazy. That being said, we do have some good data on normal values in kids. And so this publication came out of Sick Kids in 2015. And I like it because it looked at 233 kids, but their normal values are actually pretty close together. Some of the earlier normal values that were published had really wide ranges. And even if I'm super, super cautious and use a measurement value that's well below, kind of the dotted line is 3 standard deviations, the red line is 2 standard deviations. You can find a number that's kind of a cutoff that should work for every kid. And sometimes I just keep these in my head and say, oh, these could be like this is that cutoff that I use. Maybe this is abnormal. We know, though, this publication is now from 2013 out of Sick Kids. They used the 2009 diastolic guidelines, which are very old now, but looked at kids with cardiomyopathy and found that even in kids with known restrictive and other types of cardiomyopathy, sometimes they had normal measurements, and the relaxation and compliance in the same patient could not correlate with each other. They were discrepant because the pattern that the kids develop diastolic dysfunction is not the same as in adults. But it doesn't mean that the measurements they were looking at couldn't distinguish between normal and abnormal. So this is the data from that paper. And I put the red line kind of where I would have considered normal cutoffs based on that normal value paper that I showed a few ago. And you can see that really normal stays pretty above, like pretty much on the side of the line that it should. So blue is controls and all of the other colors are cardiomyopathy. And so we may not detect everybody who has diastolic dysfunction, but if your numbers are abnormal, you probably are abnormal. And if your numbers are normal, then that's pretty reassuring. So our diastolic function assessment isn't totally useless. It's just not as easy to do as adults. So I kind of propose that like this pathway isn't terrible. It's basically saying maybe there's some abnormal relaxation, maybe there's elevated LA pressure, and if there's more than one abnormality, maybe I should think about diastolic dysfunction. So I would never say that somebody has diastolic dysfunction unless it's slam dunk on an echo, but maybe we should be thinking about it if there's risk factors and there's no other cause for the finding that we're seeing. So what do I do with an abnormal, like a concern for diastolic dysfunction on a peds echo? I go back to the clinical team and they can, if they know that I'm considering it, they can think about whether there's symptoms. They can decide whether a diagnosis of diastolic dysfunction will change their management. Maybe they want to see if it's a consistent finding. But even if we think there's diastolic dysfunction, kids will probably still need confirmatory testing, either with a cardiac cath or potentially with stress echo, as that becomes more of a thing that's done in pediatric labs. And then ultimately, there are probably new modalities that will change how we assess diastolic dysfunction. Atrial function is certainly having its time, and I think there's probably measurements that are as good, if not better, than just reservoir strain. And AI and machine learning is probably going to tell us whether kids have diastolic dysfunction. So all that to say that diastole and diastolic filling are actually pretty complex, that we can't use a single measure to assess diastolic function. Echo can't be used in isolation, that the clinical history is important, but I also think it's important to have a high index of suspicion because it can be bad for patients if we ignore diastolic function assessment, and that pediatric-specific algorithms don't exist yet, but I think the use of age-specific normatives can help us identify abnormalities, but we have to understand the differences in our peds echo to interpret findings. Thanks. Hopefully some of you are still awake.
Thank you so much, Dr. Haug. That was really great. So much information in a short amount of time, but I loved it. I'm going to introduce our next speaker for the night. So next up, we have Richie Palma. He is a distinguished educator in both echo and physics, and he is currently the director of Duke's cardiac ultrasound program. And with over 35 years of echo experience, and the only man to have received Distinguished Educator Awards from the SDMS and ASE, please welcome Richie Palma.
Well, thank you, Megan. Let me just make sure I can get my slides going here. Am I able to share? Let me try that one more time. I guess I'll try to share my window, see if that works better. Sorry, just working with some Apple stuff here. I apologize.
It's coming up.
Excellent, all set. Well, thank you for the invite. I appreciate it very much. And I know Dr. Hoke said this is probably not of interest, but definitely diastology is a huge interest of mine. So I love talking about diastology as much as any other person probably in the world. So I'm actually pretty excited. But I do think when we start thinking about diastology, a lot of times if you guys ever see these new guidelines, and if you're a sonographer and you're first taking it on, you do get that kind of that 1.21 gigawatts like overload because there's so many measurements that they want to do, and maybe not necessarily obviously in the pediatric world, because obviously Dr. Hope pointed out that a lot of these diastology stuff does kind of pertain more to the adult population, but we are seeing that more and more with the pediatric population. So instead of having just a few measurements that we're doing, they've added quite a bit of more stuff. And I think like anything, when she mentioned that it's not one particular measurement is going to tell you exactly whether someone has a certain level of diastolic function. It's going to be more the supporting data, right? So doing more measurements and more of these variables are going to help you kind of get closer to finding out whether someone falls into a certain bucket, whether it's, stage 1, stage 2, or stage 3. And I think a lot of the adult population, a lot of us have felt we fell into the indeterminate. So this is definitely adding more modalities. So my job today isn't necessarily to teach you about diastology, but more some of the technical aspects of some of the measurements that we do that's really important. And as a sonographer and teaching students and fellows, et cetera, it's all about the data in and data out, right? So we want really good information and good data so we can make the proper decisions and measurements. So I do want to point out that these guidelines have been developed and looking at these different variables, but they've done the data and they've done the research, and it's not actually acceptable in certain cases. And we will talk a little bit about some algorithms, that relate to AFib, pulmonary hypertension, et cetera, but not going to be used with patients with LVADs, ECMO, et cetera, and heart transplants, which with a lot of the congenital kids may have heart transplants. So these measurements we look at, and obviously was shown a little bit earlier, is going to be the tissue, the volumes, looking at isomemic relaxation times, looking at this pulmonary vein, mitral A to AR velocities, using strain for LA reservoir, but it's going to be important. So when we start looking at these things, and this is the secondary measurements, we're going to add in more LA strain, the PI, jet, et cetera. But it really starts with tissue Doppler. And that looks at the myocardial velocities. When you talk about diastology, it is about abnormal relaxation and the compliance of the left ventricle and how that ventricle relax. And usually when you talk about which came first, the chicken or the egg, it's usually the compliance that happens first. When the heart doesn't relax very well, then obviously it doesn't receive the blood. Then secondary things occur, such as the elevation of the LA pressure and LV-EDP. So with that being said, and I wanted to point out some of the tissue measurements here, and they do bring out the ages of 20 to 39, how these tissue velocities are a little bit higher as compared to obviously the adults, where we see a lot of my patients over 65 of age, they'll have a 6 and a 7. 6, 7 will be your medial and lateral annuluses. So let's talk about tissue Doppler, because that's one of my big things that I love to do. It's based on Doppler. It's based on the angle of independence. You want to be as parallel to that motion as much as possible. This is a suboptimal angle, and this would obviously be a lot better. And so I personally prefer, and it may be changing for pediatric population depending on the size of the child, but I prefer a 5 millimeter sample gate for my lateral at 3, and I like a 1 millimeter for my pulmonary veins. So decrease any wall filtering abnormalities that could occur with a larger sample volume. The other thing, this is one of my initial papers I published way back in 2005 with my good colleague, Jeff Hill, on the assessment of diastology for the sonographer. And this is an example of a sonographer just placing the sample volume a little bit too high. And you can see this tissue Doppler is not uniform, very difficult. We're getting atrial waves up to 40, and tissue Doppler typically is around 20 or less. So we recommend, and it's really important, that you will have a patient take a breath in, breath out, and then I always perform all of my Doppler on end expiratory apnea. With that being said, we have nice uniform tissue Doppler throughout this image. So here's another example of a patient, simply nice, really crisp envelopes, really nice Doppler. But if you look, you see 12, 10, 8, because there's some variation there. This is just because the patient took a simple breath in. And again, you may say, I'm just going to average it out. No big deal. I get a 10. But if you actually did end expiratory apnea, you'll see consistent 7, 7, 7, 7, 7. So when I see variation of Doppler, I always have my sonographers go back and do expiratory apnea and get clear, reproducible measurements. That's really important because this number, we're going to divide obviously into the E velocity. It's going to help us with our ED prime, which is going to help us to assess the potential of elevation of LA pressures. What about gain? Too little, my E prime's 8. Too much, spectral broadening. I've doubled my E prime, 16. That's a big difference. So this is just right? Obviously gain properly minimized. You want to have a clear signal. We do mitral valve inflow in all of our patients all the time. You think, what's this, no big deal? I'm just going to throw that pulse Doppler in there. And a lot of us, when we think about this, and this is kind of a schematic of showing where you can place your Doppler, sample volume 1, 2, 3, 4, 5, 6. And, the question is, what's the big deal from 4 to 5 or 3 to 4? Well, if you look at this, look at the difference of your E's. It changes dramatically, even moving a couple of millimeters up and down. And remember, this is where you want to be. You want to be about 4 at the tips of the mitral valve leaflets when they're fully open. And you want to measure that correctly because, again, proper measurements, proper data in, especially when we start dividing that with our E prime, with our tissue velocities, can make a big difference. A lot of us like to do decel slopes. And this comes from, even way back when I was one of the co-authors of the comprehensive echo exam for the American Society of Echocardiography. You should never measure a decel slope if your A wave starts over 20 centimeters. And you'll see right here, obviously this one's starting at about 50 centimeters. And this can be a problem, obviously, with some of your kids who are tachycardic. So looking at the E prime ratio, again, we mentioned earlier, we're looking at the E velocity with pulse Doppler, the mitral valve inflow, and tissue Doppler. And we know that this velocity is important because it came up way back at Dr. Naga, way back in 1997. It's kind of a measurement of how the heart was relaxing, a measurement of tau, time to constant isovolumic contraction. So basically, the lower the ratio, the lower the pressure, and vice versa, higher ratio, higher pressure. So in the adult world, if you had less than 8, that meant your left atrial pressure was normal, less than 10. So the original data used the 15, but now we usually typically do the medial and lateral and get an average of 14. So if that's above that, that means your LA pressure is over 15. What about left atrium? I hope you guys are measuring left atrial volumes. It's a lot better than a linear dimension, but it's important to point out you want to obviously, not measure the tenting area. You want to avoid the pulmonary veins. And when you measure, you want to make sure when you go from the 4-chamber to the 2-chamber that your atrial length is very good, very close to your 4-chamber view. So in our documentation, it says if you go from the 4-chamber to the 2-chamber view, you should be within 5 millimeters of those measurements of the atrial length, because you want to compare apples to apples. And that's really important because, again, you don't want to be undercutting that 2-chamber view, and that LA volume won't be as accurate. A little bit about the pulmonary vein, which was just mentioned earlier. So looking at this atrial reversal, so this atrial reversal is the same thing that happens during atrial contraction as the mitral valve inflow, the A wave. So typically you would think that duration is the same as the pulmonary vein AR velocity, and it should be. And we all get this little bit of reflux backwards because obviously the pressure in the left atrium is a little higher than that of the pulmonary vein. So anything over 35 centimeters, it used to be 30, they've moved it up to 35 centimeters of retro flow in the pulmonary vein would be considering a high left atrial pressure. But the also thing you want to do is you want to be able to compare the A duration of the mitral valve inflow, which you see right here, to this AR flow. So this combination of looking at this, it should be the same time. If this AR velocity is greater than 30 milliseconds, been highly, correlative to high left atrial pressure. So when measuring this A wave, as far as the AR duration, you're not looking for the amplitude of the A wave. So I always recommend that you want to know exactly where the A wave ends. So I typically will put my sample volume right behind the mitral valve. I want to see that closure click so I can actually see the duration of the A wave. So isovolumic relaxation time, as mentioned earlier, is becoming more and more important. It is the first stage of abnormal relaxation. So when you start looking at this measurement, it's going to show up more and more with different disease states. When you start seeing these occur a little less than 70 milliseconds or having a little bit shorter of these isovolumic relaxation time, that's been showing that this could be elevation of that left atrial pressure. So the question is, should we use PW or CW? Well, the answer is, and it's in the guidelines, that you should definitely use continuous wave Doppler. Placing your sample volume in a 5-chamber view, and you want to place it in between the mitral and the aorta. You're like, well, I don't want to do that. I typically go here or there. Well, in this case, you want the contamination. You want to see the mitral valve inflow nicely. Then you want to see your aortic flow. And again, you're going to see this closure click of this aortic valve, then the mitral valve opening. Obviously, using a high sweep speed is very important because this measurement is very small, right? So speed up that sweep speed. I like at least 100 for a sweep speed to measure that isovolumic relaxation time. And again, the reason why this is so important and how they've been adding it to the guidelines is that it's been used for different special populations. So with AFib, you talk about 65 milliseconds, restrictive cardiomyopathy, MS, MR. And one of the tricky things, not necessarily you see with kids, but with adults, is mitral linear calcification. That throws off your tissue values, your ED prime ratios, everything. So adding in, obviously, the isovolumic relaxation time has been very helpful. The mitral valve L wave. So this is during that diastasis part where we see this little bump. And obviously a lot of young people, which you guys work with every day, the children, they can have this L wave. We can see this with sometimes athletes, patients with bradycardia, et cetera. But the key is if it's seen, it's kind of that little extra bump in the middle of diastasis. But now they said it should be greater than 50 centimeters. So a little bump is fairly normal. But when you start seeing it over 50 centimeters, that would be considered abnormal. And I mentioned LA strain, reservoir strain has been added, so -18, but I think I saw some numbers that the Hook was showing a little bit larger number. Was it 22, I believe? She can probably, comment afterwards. And then again, I wanted to put down some of the numbers here that she gave me as far as the kids' ages from 31 up to 24 years of age, 2 to 5, 5 to 11, and 11 to 18. And just a quick note as I finish up, diastology can be done in some of our other disease states like mitral calcification, as I mentioned, pulmonary hypertension, and AFib. A lot of our kids, congenital kids, obviously can develop pulmonary hypertension, due to their obviously congenital abnormalities that can develop this. So this might be very helpful because we do want to differentiate pre-capillary versus post-capillary pressure elevation. So in MAC, we're going to use the mitral valve EA ratio and look at that ratio if it's less than 0.8 versus over 1.8, excuse me. Then if it is abnormal, obviously we're going to use the isotonic relaxation times, which again is going to be in that numbers of 80. Pulmonary hypertension, you're going to use the EA again. Then you're going to use your reservoir strain. If you don't have reservoir strain, then you're going to use your lateral ED prime ratio, and that will tell you whether it's elevated or not. And in AFib, you're going to use these measurements, and you're going to look, obviously, if you have 2 or 3 of these, if all of these are abnormal, then you can move on to LARS, pulmonary vein S-day ratios, look at the patient's BMI, et cetera. And again, you can get an idea of whether this person has elevated pressure, stage 1 or stage 3. So that was just a quick little thing to kind of point out some technical aspects. And again, it's going to be a little bit different in your congenital patients, but I figured I'd just give you a little lesson on maybe how to perform those things. And it was a pleasure to assist you guys and work with you.
Thank you both so much. That was really excellent. Very tough topic, I think, for everybody. It's easier for me to say as a fellow. But we do have one question or 2 questions. The first is, are either of you aware of pediatric echo labs that are routinely using atrial strain?
So speaking for our lab, it is in our sort of our function protocol. So kids at risk for left ventricular disease. I think we're at the state where right now we are trying to do it in more children to get reliably better at it and more comfortable with it. There is actually a great question as to whether there is a place in our reporting template in which to put it, and I don't actually know if there is, which goes to show that we're not really using it clinically that much yet. But it's something that when it is there on the picture, it like piques my interest if it's very low, and I may use it like to confirm what I'm thinking about something like other things with regards to diastolic dysfunction, but I don't think we're reliably like using it as a criteria to call diastolic function. It's something we're trying to study more. Interested to hear from in the chat if anybody else is using it or what the state of LA strain is across other pediatric labs.
While we wait for that, there's another question about if you all frequently measure tricuspid inflow E and A wave velocities.
As an adult sonographer, the answer is yes, especially if you're looking at patients with RV, diastolic dysfunction. And studies show that if you do the E wave and do tissue Doppler, the E prime, anything greater than 6 would show some evidence of RV diastolic dysfunction. So that's with the adult population that we do at Duke. So
we measure it, I think, more out of habit. I can't say that we are clinically using a lot of the tricuspid valve E to A ratio. I think there's so much both respiratory variability and age variability and blurring of the E and A that it's a little bit difficult. But I do just they are sometimes measured, but not super clinically used.
And then Dr. Hauk, I have a question for you actually. What is your opinion currently with diastology in terms of neonates?
I was talking to somebody at a PH conference this week, and I was like, "That is a question I get every time." Um, I think I think we are learning a lot more about the neonatal myocardium and what normal is. I think diastolic function assessment in those kids is difficult because we will almost never have gold standard cath data to say whether the echo parameters truly correspond to abnormal filling pressures or in the cath lab. There's a lot of new data that is coming out, and people are trying to get technically very good data to better understand what's normal and abnormal. So, like just last year, there was a systematic review meta-analysis of tissue Doppler velocities in less than 20, 30, at different gestational ages, both before 7 days and after 7 days, to try to get a sense of what the maturational changes are. And I think that's an important first step. I think right now the range for measurements is pretty difficult, specifically for tissue Doppler. But I do think that we can suspect diastolic dysfunction in those kids, either with like very low tissue Doppler velocities. I've heard that some labs will use an ED prime of like 18 in neonates, but I think the things that I look at the most are if there's LV systolic dysfunction in a neonate, and pulmonary hypertension, it makes me wonder if there's diastolic dysfunction, and truly because systole and diastole are so coupled that there's probably some relaxation abnormality if you don't contract well. I think your LA size, if you don't have a PDA, is a really good like clinically marker that the LA pressure might actually be high and it might be clinically important diastolic dysfunction. I think your atrial septal gradient, so most of these kids have a PFO, so if you have high velocity flow across your ASD, or if you have left to right shunting and pulmonary hypertension, then I definitely wonder whether there's a component of LV diastolic dysfunction that's present and maybe even contributing to the PPHN or to the pulmonary hypertension. So I really like to look at my LA and then my LV function while making sure that the like true calling of diastolic dysfunction in these neonates across the different age range and gestational age that we're like really trying to get as good of data as we can. But we know that the neonates, they have stiff hearts, they have stiffer hearts than term babies. They have like premature babies do, that they stay abnormal for a long time. So I think diastolic function in that population probably is like really important because it's probably more common in that population than it is in older kids. That was a very long answer.
No, it was great. I loved it. Thank you. Another question I had, and this could go for either one of you, but when looking at kids who have congenital heart disease and even getting up into that adult congenital heart disease stage where they are fully repaired, say they're a fully repaired Fontan, and we're looking at cardiac transplant, and we have a failing Fontan, are we going to kind of assess diastolic dysfunction differently at each stage of their repairs, or is there a certain standard that we're kind of looking at right now for that, if either one of you know?
Yeah,
Go
I
ahead,
think
Doctor.
single. Richard, do you have thoughts on the
No, I
adult
said go ahead.
congenital
No, go
population?
ahead.
Okay.
Yeah,
Um,
I was going to comment on stress echo afterwards, but go ahead.
yeah. I think diastolic function assessment on echo in single ventricles remains difficult. Their atrial anatomy is abnormal, but maybe there's a role of strain. Like I don't think I would ever call it without the cath findings. If there is a trend in worsening of their tissue Doppler velocities or more flow reversal in their pulmonary veins over time, like once I know it's a problem, I may trend those things to consider it. But I still think globally, like the yay or nay, this is diastolic dysfunction and this is how bad it is in kids in general and in congenital heart disease specifically is a little bit tricky.
Yeah, I mean, you mentioned this earlier, but anyone with systolic dysfunction is going to have some form of diastolic dysfunction, right? So that's kind of goes hand in hand, right? So the assessment of LA pressures is important too. So assessing diastology can be tricky in the kids, but you can still assess LA pressures. And I'm a big fan of hemodynamics, et cetera, such as looking at the MR jet when the absence of an MR jet, and then obviously seeing what someone's LA pressure is. So things like that is important. Looking at the pressures in the lungs too, right? Because it's all backing up, right? So that's important, I think, to assess. And I think diastolic stress echo is becoming more and more prevalent. I don't know if you guys are doing a lot of stress echo or not on your children, but for diastology, it's been kind of really interesting because it's been seen in stage 1 patients who have dyspnea whose resting echo doesn't really match their symptoms. So what we do is we do stress echo on them, and we basically look at the tissue Doppler, TR jets, et cetera. And usually if your ventricle is not doing well, everything should improve, such as your E should get more higher velocities because of increased cardiac output. Your tissue velocity should increase, stays the same. So what happens, you get increased ED prime ratios with exercise. So because of that, we end up having elevated LA pressure, wedge pressures, and that's why these patients becoming short of the breath. So I think diastolic stress echo in these kids in the future, just symptomatic wise, to see if they develop more symptoms with pulmonary hypertension secondary to maybe left heart failure, could be things you could see in kids more maybe.
All right, wonderful. I think that takes us to the end of our questions, and typically our Q&A goes until 45 after, so we're right there. I want to thank once again our speakers, Amanda Hauk, Dr. Amanda Hauk from Lurie Children's, and Richie Palma from Duke. And I would be remiss if I didn't thank our wonderful and talented moderators once again, Megan Conoyer from Advent Health, who's a pediatric echo educator there, and Matthew Theo Harakis, who's at Nemours, second-year fellow, looking to do imaging. If we can bring up the slides again, Bailey. Wonderful. All right, let's go to the next thing that we will do is ask Dr. I think it was Dale Burkett from Colorado. Are you still on?
Yeah, I'm here.
Wonderful. We've got a wonderful sponsor highlight to see what is new and interesting at Colorado. Thank you so much for joining us.
Yeah, thanks for a great session. I'm not sure I'm more relaxed about diastolic assessment after this, but it is fascinating to see where we're going at this. I do think this is an area that'll be ripe for machine learning. I just think you guys have already highlighted a lot of the complexities with assessing diastole in kids, and especially those with congenital heart disease. So the mystery in my mind continues for how best to do this, given, as you saw in the chat, most of the major echo labs, I think, probably in the United States are not doing atrial strain and a number of other kind of typical assessments for diastolic function. But yeah, we appreciate the opportunity to host kind of the sponsorship for this. We're looking forward to seeing a lot of you at ASC this year, which is in kind of Denver. You'll find out quickly that the Gaylord Hotel is not really by Denver, but you can see the mountains, so that's a plus. But we're looking forward to connecting with as many of you as possible there. We are in the process of continuing to hire here at Children's Hospital of Colorado. We've had a lot of hires. Courtney and Carly run our echo lab as sonographers, have done an incredible job of really creating a great kind of tiered job structure system there, and have single-handedly hired 17, potentially 18 now sonographers in the last 2 years. So incredible growth in our group. We've gone from 11 physicians to now 20, and we're looking for one kind of final physician hire as well. Unfortunately, not for somebody who does fetal echocardiography, which has proven incredibly difficult. So hopefully able to connect with a lot of you at ASC this year. But if any of you guys are looking for potential relocations, just let us know. And Courtney and Carly are great assets. Myself, Dale, again, run the Echo Lab and the 3D Echo program at Children's Colorado. And then Adel Unisai runs the cardiac imaging group with some oversight of fetal and cardiac MRI. So both of us are good people to reach out to. So thanks again for allowing us to sponsor this, and from a former graduate of our program, Dr. Hauk, who crushed it. So
Thanks, Dale.
Wonderful, thank you. Bailey, if we could bring up those slides again, just to show our next session. So once again, thank you for our sponsors. Colorado is a sponsor who has been with us for a couple of years now, and we thank them for their sponsorship. One of the benefits of sponsorship is that depending which level you're at, either most or all of your physicians and sonographers can become members of SOPE. And if you found this diastology lecture a whirlwind, which I certainly did, and you want to review it on the recordings on the SOPE website, you have to be a member to view those. So if you're not already a member, consider getting your institution to sponsor or become an individual member. On April 28th, 2026, same time, same place, we will be presenting on CCTGA. And I think for the actual presentation, we'll have a slightly more creative title like we did this time. This has been relaxed. It's just diastole. I'm Ray Lorenzoni, one of the chairs. Nitin Madan is the other chair. And we thank you for your attention tonight. It's been a great session.